coming back to present. And so obviously for those joining us, we have Dr. Jeff Snell presenting today on self-awareness. Laura Brown, Don Terry, thank you both for joining as well. For those of you who are regular attendees, welcome back. If we have any new individuals joining us, this is coming to you from QLI based in Omaha, Nebraska. We are a post-acute rehab facility specializing in helping individuals with brain and spinal cord injuries, chronic pain, and any other sort of complex injury get back to life. And today's topic is self-awareness. Before we get to that, some housekeeping. As a reminder, there is going to be one poll question, and it will happen at the end of this presentation. You need to fill out that poll question. We'll let you know. It's just a true-false question, so that's what it looks like. You'll fill that out, and that helps you get your CEUs. The other thing that helps get your CEUs is you will get an email before the end of today. That email should have a link where you fill out the evaluation for this presentation. Your feedback is always important and welcomed. And doing that, you will automatically get sent the slides and the certificate for your CEUs. So that happens automatically. Sometimes there are some issues with firewalls and things like that. But other than that, once you submit that, everything's automatic and there's the rest is out of our hands. So we'll do one more reminder of that, but we appreciate your patience in us getting that back out to you. So with that, Jeff, let's talk about awareness.
Okay, I'm on it. So for today's presentation, there are three main points that I'm going to hit on, and I really want you to carry away from this. One is impaired self-awareness is relatively common after brain injury, especially in moderate to severe TBI, where multiple neural networks are compromised. The consequences of this impaired self-awareness directly impacts rehabilitation efforts and outcomes. So we need to be aware of this and pay attention to it. And it should be clinically addressed when identified in an appropriate manner. So it depends on the severity of the issue, and the reason that we want to address it is because it is important in improving outcomes for the patients that we serve. So self-awareness, defined in the Oxford English Dictionary, is a conscious knowledge of one's own character, feelings, motives, desires. It's a term that's generally thought of as an internal psychological state, somewhat synonymous with insight. Prigitano and Schachter in 1991, in terms of brain functioning, said that awareness is the ability, the capacity to perceive the self in relatively objective terms while maintaining a sense of subjectivity. So we're talking about a level of accuracy of self-assessment that approximates that of an independent observer. In other words, what I think I am capable of, those around me would confirm, yeah, he's able to do that. Impaired self-awareness would be, of course, that my impression of that, my perception of that differs from those independent observers. To have insight is to have accurate and in-depth understanding. This can be of self, or it can be of constructs, concepts, objects. In this particular case, we're talking about insight regarding how things may be different after an injury, or how such differences may impact a patient moving forwards. Within that construct, we'll also be reviewing today self-assessment, or knowledge of one's own abilities, strengths, weaknesses, and particularly deficits that may exist as a result of an injury. Now, I mentioned above the alignment of our self-awareness with that of independent observers. One of the first hints you get that the patient that you're interviewing doesn't have accurate self-assessment is when you're interviewing them and some significant other or parent or spouse is standing in the background shaking their head at the responses that are being provided by the patient. In that case, you can infer that there's a discrepancy between what the patient perceives and what independent observers perceive. This is often your first big clue that a patient's self-report may not be accurate. Laura, I'm sure you see that when you go see folks occasionally and you're asking them questions about their injury. As stated by Dr. Mark Shearer and his colleagues, it's conceptualized as a neurological deficit rather than psychological denial. Denial refers to a psychologically motivated symptom that serves to defend against threat to self-concept or self-esteem. We all have some degree of denial, and it gets us through the day feeling good about ourselves. This implies that there's a knowledge or understanding of deficits that may exist, but it denies them in order to preserve a positive sense of self or to maintain a positive self-concept. What we're talking about, however, is a neurological deficit that is a direct consequence of a brain injury. It is a disruption of the neural circuitry necessary for accurate self-assessment and for accurate self-awareness. Now, in medical terms, there's a big old complicated word that is associated with this when somebody doesn't have accurate knowledge of their own deficits, and that is anosognosia. This is a neurological condition where the brain does not have the capacity to recognize one or more health conditions, or more specific to individuals who have a brain injury, it's a cognitive unawareness of the deficits associated with the disruption of the relevant neurological nodes and pathways in the brain that have been injured. Again, this is very different than psychological denial, where I don't want something to be true, so I don't acknowledge it, or I psychologically suppress that knowledge. No, this is a neurological lack of ability to perceive and therefore be aware of a given deficit. The word itself comes from a Greek background, as many medical terms do. The A on the beginning, you tack A on the beginning of any medical condition, it means an absence of that. It is without that. So A means without. Nosos is disease. That word means disease in Greek. And gnosis, with the silent G there, that means knowledge. So literally the word means a lack of knowledge of the disease. And in the case of brain injury, it is the lack of knowledge of the injury or insult that produces the symptom. But the term has been applied nonetheless. It's this latter concept that we're going to be talking about today, and it's something that we often encounter at QLI, as Steve alluded to there, given the selection factor of the patients that we serve. It tends to be seen more in cases of more severe injury, and because of the patients that we see that are referred from acute rehab centers where there's an ongoing intense rehabilitation need after all those earlier stages that precede referral to QLI have passed. So naturally, these referrals tend to be individuals who have experienced severe neurological insults and who have extensive rehabilitation needs. So we're more likely to serve a population that contains a higher percentage of individuals who exhibit impaired self-awareness than you're typically going to encounter in an acute setting. In an acute setting, particularly a primary care setting, you're mostly going to be seeing individuals with concussions and mild injuries. That this is not going to be an issue for the vast majority of those cases. So you're going to see it typically only in moderate to severe injury. Now, again, the numbers vary depending on the study that you're looking at, but typically around 30 to 50% in most of the research that I've been able to uncover, generally in the neighborhood of 40 to 45% of individuals with moderate to severe TBI demonstrate deficits of awareness, deficits that are clearly evident to family or to therapists and are not acknowledged by the individual. Or if they are acknowledged, they're judged to be inconsequential, they're discounted, or they're otherwise rationalized, or just ignored. It can be relatively uncommon, again, in mild injury, but more likely as the severity of injury increases. While some individuals may accurately describe their post-injury changes, others may argue very persuasively that they're no different than they were in their pre-injury state. Like most brain injury-related deficits, the tendency is for a more dense expression of this deficit earlier in the recovery process. So again, closer to injury tends to be more likely, with a gradual resolution or improvement over time. Again, this represents the reconnection or establishment of new connections within the brain, the neuroplasticity that allows for recovery of functions. But also, like most things, when we're talking about severe brain injury, there are some individuals for whom this remains a significant problem for months or years after injury. So again, it just reflects the complexities of the underlying neural processes and the nature of the injury itself. If we're not aware of a deficit, we're probably not going to be motivated to compensate for it, or even know when to compensate. It can result in refusals or minimal engagement within the rehab environment because the individual doesn't see the deficits. It's often associated as well with poorer long-term outcomes. Our ability to have accurate self-awareness is a function of our brain. Compromise to the neurological function associated can result in a loss of that ability, as with any neurological process. If the information our brain has given us about our capabilities and capacities is inaccurate, then that incorrect data is our reality. That's why you cannot, as Steve mentioned, reason away the inaccurate reporting with which a patient may exist. One way I've always thought of this is it's like a carpenter with a tape measure where the numbers are somehow wrong. The numbers are off. Every time you measure something, you're going to get a consistent reading. It's going to be consistently wrong. Our awareness is that tape measure. It's what we gauge our performance and our abilities against. And if our awareness is off, the information that it gives us is similarly inaccurate. From the standpoint of outcome measures associated with return to work after brain injury, researchers have reported that vocational outcomes appear to show a relationship with accurate self-awareness. In other words, a positive relationship between return to work and accuracy of self-awareness. Those individuals who demonstrate better and more accurate awareness have better employment outcomes. This highlights the need to identify and provide treatment when you have impaired awareness. These neurological deficits are associated with functional abilities, and therefore they can result in impairments that compromise particularly safety or the functional abilities involved. Now, this is a heads up. Most of the time when I'm giving a presentation, I am relying entirely upon valid, established scientific data. This one is just my own opinion. This is the way I attempt to understand what might be happening in the brain when we have impaired self-awareness. Now, the brain does not operate like a computer exactly. Our memory functioning certainly isn't dependable as that written to a hard drive or a thumb drive, but there are similarities in many functions. One of them is we have within our brain a sense of self. That sense is subjective in nature, but it represents the sum total of our experiences, our knowledge of ourself, so to speak. It reflects what we know of ourself in terms of abilities, capacities, what we're capable of. To me, that's similar to the registry file on a computer. Your computer has on it a registry file. It is a listing of all of the contents and where they are located. It's a way to access information. And that has to continually be updated on an ongoing basis for it to be current and accurate. On a computer, if your registry file gets corrupted, you can lose access to files, programs, documents, because the computer doesn't know where they are on the storage medium. It's also a file that can be repaired or edited. Now, this is a file you don't want to start editing if you don't know what you're doing, because it's a map of where information is located within that system. In this analogy, our sense of self is written to some registry, a file, somewhere in our brain. I can't tell you where it's stored, but it's something that we continually update over time with experience. We know long-term episodic memory is relatively invulnerable, even in severe brain injury. Our name, our family members, where we live, the language we speak, our long-term knowledge, all that information that we've acquired and repeated so many times, that data doesn't go away when you have a brain injury. You can have trouble accessing or communicating that information, but that information tends to still be there. This information also includes our abilities, our capacities, our capabilities. But if we can't update that file for some reason, if we can't overwrite old information with newer and more accurate data such as I had an injury and it has compromised my ability to do certain things. If we can't update that registry, then when we retrieve data from that registry, it's inaccurate. It represents our long-term pre-injury knowledge of self, not our post-injury knowledge of self. For us to have accurate and updated self-awareness, it is a complex interaction of several neural networks, many of which have overlapping functions and connections. So all these different parts and pieces and many more play a role in this process. Now, the individual may not observe mistakes, errors, or impaired performance. This lack of self-monitoring is related to our internal representation of ourself and the inability to integrate new information into that self-perception. This is often related to a disruption of the neurological subsystems, such as sensory integration, that mediate our ability to accurately self-monitor. Even if a person has awareness of a specific error or impairment, impaired reasoning or thinking skills may lead to an inability to make the connection between a performance and the outcome, the difference between knowledge and understanding, for example. Attention and concentration can play a role because you can have difficulty taking in new information or feedback. You don't notice the problems as they're occurring. Now, again, all of us do that from time to time. If you've ever misplaced anything, you've had a momentary lapse of attention when you put it down and you didn't really note where it was and you have to go looking for it. But this can be much more common, certainly after an individual has a brain injury where some of these basic neural systems are compromised. Memory also plays a role. If you have trouble retaining and therefore integrating the new self and being able to recall that, you might notice it in the moment, but being able to then think of that later on. Forgetting problems when they occur, you see yourself as your premorbid status. That's an interesting thing when it comes to memory. People who have mild memory problems tend to be aware of the fact that they have memory problems. People who have severe memory problems are unaware that they have memory problems. Because if you don't remember that you have forgotten something, you don't recall later that you forgot something, then your memory is perfect. So it's only people who have grossly impaired memory who truly feel like they never forget anything. Emotional functioning plays a role in this as well. Difficulty accepting those changes. Again, I said psychological and neurological differences there in that impairment of self-awareness, but they can both impact each other as well. Difficulty accepting the changes, being unable, unready, or unwilling to deal with major changes in life plans, hopes, and goals as well. This is an important one because even healthy, uninjured individuals engage in inaccurate self-representation at times. Again, these are positively linked to well-being and positive self-esteem. We don't spend all day thinking about all of our faults. We're able to some degree, suppress that a little bit, and it is positively associated with our own sense of self. The other is attribution theory, which applies here as well. Attribution theory is if an outcome is good, then it was under my control. I was directly responsible for it. I should be praised, and it's very good. If the outcome was bad, on the other hand, well, that was beyond my control. It's somebody else's fault. I shouldn't be blamed for it. And besides, everybody's making a big deal out of something that's not that really much of a problem. So attribution theory is why if somebody cuts you off on the highway, they're a jerk. And if you cut somebody off on the highway, there was something that happened at the last second and I had to react, and that's not my fault. So attribution theory, again, plays a role in our own self-concept. As described by Crossan and colleagues, the pyramid model of awareness proposes 3 interdependent and hierarchical levels, the first of which is intellectual awareness. This is the bottom of the pyramid that provides a foundation for the higher levels. It's the ability of a patient to verbalize or recognize that a given deficit exists or that a particular function is impaired. So again, this is the base level of even being aware that I am different after my injury than I was previously. I can tell you that I have a particular deficit. Emergent awareness is the ability to recognize problems when they occur. So when you see intellectual awareness of a given deficit, but the patient doesn't use that knowledge to monitor ongoing performance, they are probably more in that emergent phase. In other words, if an individual has intellectual awareness that a deficit exists, but doesn't show the ability to use that knowledge in the moment. Even though they acknowledge that they have this impairment, they don't recognize in the moment unless others point them out. Or it's only when that error occurs that they're able to acknowledge it. As recovery progresses, they may begin to recognize the problem when it occurs, but they don't change routines to accommodate that issue, or they keep making that same error despite recognizing it in the moment. And again, you can see how memory plays a role in this as well. Anticipatory awareness is kind of the capstone of the pyramid. It's the ability to recognize that a problem exists, that it's likely to occur as a result of a given deficit, and to anticipate our plan for those situations in which that is likely to occur. An individual at this level can modify their behavior using that knowledge of the impairment to anticipate the circumstances in which that impairment is going to cause a problem and thereby avoid that error.
Jeff,
Yes.
I know you're going to get into this with some like the so what and like what do you do about this and that sort of thing. But if you go back to that previous slide, I think wouldn't you say that this is one of the reasons why contextual training is really, really important? Because
Definitely, yes.
intellectually, I think we see a lot that people can maybe even acknowledge where they might fall short or what their abilities are and have some level of awareness. But that emergent anticipatory component is kind of the application of that.
Yes.
So why we see such a gap even when we put someone in what I would say simulated events and types of experiences, even at QLI, why there's still a gap when they go home or when they're in the real world is because they have to apply their intellectual awareness and get it to that emergent anticipatory component. So
yes.
maybe just
And
to
get it to the
that's
stage
kind
of
of where we're heading, right?
generalization. Mhm.
Yeah, the generalization, but that's kind of where we're heading with this, right? Is this
Absolutely.
difference between being able to say what needs to happen or what is happening and actually delivering on it.
Yeah, and we're starting at the level of an individual who just doesn't have that awareness. And I'll talk about a few of those cases as well. Self-awareness definitely is not an all or nothing kind of construct. You don't have to be 100% of your deficits to be much, much safer. An analogy that I've used over time with awareness is this. Let's say you live on a second floor apartment. Somebody sneaks in at night, cuts a big hole in the middle of your living room floor. So now you've got a hole 3 feet across down to the first floor. Now, the first time you walk across that room, if the room is completely dark and you're not aware of it, you're at very high risk of falling through that hole in the floor. It only takes a little bit of light to see that there's a problem there, but as long as it stays dark, that hole is going to be a problem. Now, if you're aware of that, you can walk around it. You'd probably be on the phone pretty quick trying to get somebody to come over and fix it and figure out who the heck came in and cut a hole in your floor to begin with. And you'd put some barricades up around there so that you wouldn't inadvertently fall into it. You're used to walking through the middle of the room. So that would be anticipatory awareness that we mentioned in the last slide, putting something in place so that I avoid the problem or so that others avoid it as well. But if you remain unaware of that hole stays a huge danger. The risk is only mitigated by your awareness of the problem, which allows you to avoid the area or put something in place. It's also possible that somebody else could be there who could cue you to the problem and protect you by whatever means is necessary to keep you from injuring yourself. To be absent awareness of your abilities, and in particular your deficits after a brain injury, is similar in respect that individuals may put themselves into situations where there is a huge risk because they're not aware of the mismatch between their capacities and abilities and the demands of what otherwise would be a familiar environment. Take driving, for example, something that as an adult you don't really think about, but it's a very complicated process. Involves processing speed, attention, gross motor control, fine motor response, and a host of neural networks working together in a coordinated manner. There are also risks over which you have no control whatsoever, what the other drivers are doing at any given moment, your ability to attend to and respond to that. But if I have significant deficits in one or more of those systems and I'm not aware of those deficits, I can put myself and others at great risk, very common after brain injury. With a little bit of awareness, the risk that I'll try to do something beyond my capacities decreases. You don't have to have a brain injury to have these risks as well. The reason we don't allow people who are intoxicated to drive automobiles is because of that risk of greater risk of causing an accident, hurting themselves or hurting someone else. Self-awareness is not a unitary disorder, and therefore there can be dissociations between different domains of awareness. Cognitive abilities versus physical abilities. One can be inaccurately self-aware as well in both directions. Now, we're primarily here talking about individuals who are unaware of deficits or impairments, but I've also seen, particularly in milder cases or in cases in which their recovery is more advanced, to over-attribute impairment, to rate yourself as worse at a given ability than you actually are. This latter finding of over-attributing errors to the injury is more likely to be encountered outside of moderate to severe injury, or like I said, when people are further along in recovery. So again, misplaced my keys. Well, that's my brain injury. Did you ever misplace anything prior to your brain injury? Well, then that can also be attributed to normal lapses of attention as well. Earlier studies and theories of impaired self-awareness after TBI noted that individuals tended to be more self-accurate and more self-aware in estimating their performance on physical or observable tasks as opposed to non-visible or abstract processes, cognitive, emotional, social function. Now, this isn't always the case, and in cases of dense impairment of self-awareness, it extends to things that are physically observable. For me, one of my most striking clinical experiences was early on working in an acute hospital setting where an individual seated in a manual wheelchair pushed by an attendant who was in a body cast from his neck to his ankles challenged me to a foot race in the hallway to prove to me that there was absolutely nothing wrong with him. I did not take him up on his offer. Studies have demonstrated that individuals with impairments of self-awareness tend to demonstrate better awareness of current impairments than the future consequences of those. Again, the difference between emergent and anticipatory awareness. This little graph here just kind of shows between low reactivity and high reactivity how an individual typically emotionally responds to awareness, low awareness or high awareness. With low emotional reactivity, it's indifference either way. But if you have low awareness and high emotional reactivity, in other words, I don't think there's anything wrong with me at all, I am going to be angry. I'm going to be frustrated. And that's, Steve, I think what you were alluding to often with the difficulty clinically with working with an individual who has such low awareness. That individual is reacting like you or I, without a brain injury, would react if somebody put us in a van, took us to some place and said, you need to stay here because you've had an injury. And I'm going, you've got me mixed up with somebody else.
Mhm.
I'm going to be angry and frustrated, and that anger is probably going to increase over time. Now, you see that sometimes as people go from total lack of awareness, dense lack of awareness, even from a standpoint of emotional reactivity. And they have previously been engaging in the things you've asked them to do in an almost robot-like fashion. You're talking about Ranchos level 4, typically 5. But now they start to get more awareness, a little bit more awareness, and they start moving from anger into depression, or they start moving from no reactivity into anger. This is a case where somebody's actually neurologically improving, but behaviorally they look worse. Some individuals, unfortunately, have to go through this progress on the way to more anticipatory awareness, on more recovery. But the emotional reactivity typically associated with higher awareness. If you are aware of your deficits and emotionally reactive, it's going to be depression.
Mhm.
It's going to be a sense of loss. And even from the highest of anticipatory, the realization of how things in my life may be different as a result of this injury and ongoing issues that I'm having to deal with. Because just from a cognitive behavioral therapy standpoint, all of us in whatever situation we're in, if it's a bad situation, we can't ever see it getting better often. So the ability to look at that and assume that it's going to get better is something
Well,
that also has to be fostered.
and just clinically, it creates a little bit of a moving target.
Absolutely. Yeah.
You know, so on the one hand, that person who's getting angry, you try to give them a little bit more control, which is usually one of the first places we start, but then that can lead to having to reason with them, which can be problematic. And then you see that increase in awareness, and then it's like, well, they're not motivated anymore.
Yeah.
So you have to be really functioning in a real-time iterative way clinically to respond to that, like you said, recovery, which is a good thing, but it creates more challenges in different areas.
Yeah. And the attribution of where those impairments are coming from with that
Mhm.
poor awareness. I've seen numerous cases at QLI, a few that stand out for me particularly, for individuals who didn't have that awareness at all, even in the moment. And then as they start to develop more awareness of the fact that they are having those deficits, attribute that to whatever you're doing is causing me to be worse. When I came here, I was completely fine. There was absolutely nothing wrong with me. As a matter of fact, before I came here, I went on a vacation. I can tell you where I went. No, you were in the hospital. No, I was in Bermuda. And now all of a sudden you guys have got me here, and all of a sudden I've lost my sense of smell and I've lost my sense of taste, and I can't do this and that. What the hell are you guys doing?
Mhm.
That kind of reaction, which again represents a neurological improvement, but an emotional and behavioral decline.
Yeah.
In a study I'm going to jump to here, published in 2014, the researchers found that there was a big difference in brain activation in certain pathways within the white matter, the insula, the tracts of the brain in which communication occurs in different parts of the brain. They used a research paradigm that involved impaired error processing. So in other words, did a person recognize when an error had occurred, and made that a marker of more generalized self-awareness. Now, differences were found greatest to be in aspects of that insula, the white matter within the brain, the parts that connect the frontal lobes to the parietal lobes. In other words, the frontal for the monitoring aspects, for awareness, for attention necessary to attend to and be aware of errors, and the parietal lobes, which are implicated in conscious awareness of information. To some degree, the associative aspects of pulling together the so what of all the information that our brain is getting in order to make sense and put in context what is happening. This image represents one of the findings from that study, and it demonstrates the reduced connectivity within the dorsal anterior cingulate cortex, again, dorsal top, anterior front, cingulate cortex of the white matter there, within the frontal lobe. And that's how information, again, is being passed from our immediate attention and awareness back to the part of our brain that gives us conscious awareness and associates that with what is happening in our world right now. So this critical pathway of communication between the frontal lobes and the parietal lobes is very much indicated. The figure on the right, which reflects individuals who showed high performance monitoring, there was more activation, there was more information being passed from the frontal lobes to the parietal lobes. On the other hand, there was less for those that were low performance monitoring. So that awareness was better when there was more information being passed from the frontal lobes back to the parietal lobes. Similar disruptions of white matter communication breakdown were observed in other aspects, the right inferior frontal gyrus, the right middle frontal gyrus. Again, both of these areas show significantly less functional connection to the rest of the brain for individuals who show poor awareness. So at least in this study, there was a reduced amount of information being passed along. Researchers stated that beyond this highly specific finding, global self-awareness decline also was likely to be an emergent property of interactions within large-scale distributed networks. So it's what we all see when someone has had a severe TBI. There are usually areas of focal damage, but then there's also diffuse axonal injury that compromises communication from several different aspects of the brain. Several studies have also correlated the presence of impaired awareness, more so in right hemisphere, particularly right parietal lesioning, but this is not consistent in all of the literature. In my own professional experience, individuals with right hemisphere dominant neurological insults have often been less likely to demonstrate accurate awareness. In other words, they are more likely to have impaired awareness, be that of specific functioning or from more global aspects. From a clinical standpoint, in working with individuals who have experienced a moderate to severe brain injury, you often don't need a highly sensitive instrument to tell you when a patient has significant limitations of self-awareness, particularly in an environment where, like QLI, where we're typically only working with individuals whose injuries are deep into the severe classification when it comes to brain injury. When you have a patient, Laura, I'll take you as an example. If you go to Craig Hospital to see somebody and you are talking to somebody who clearly has documented severe traumatic brain injury, And that patient's telling you there's absolutely no reason for them to be in the hospital. They didn't have any kind of accident, and it'd be just fine if you would politely get the hell out of my room, please. That typically will bring you to the conclusion that either number one, you're in the wrong room, or number two, that individual does not have accurate self-awareness. And that is the density of lack of self-awareness that you can often see in cases of severe injury in the acute setting. There are instances, however, in the acute setting where mild to moderate injuries may also have a need for formal assessment of awareness, particularly in that, like all underlying cognitive processes, self-awareness isn't something that can be directly measured. It has to be inferred. That chasm of separation between what the patient perceives and the mutually agreed upon reality that everybody else involved with the situation has is something that is really striking the first few times you see it. You wonder, with all the evidence around this individual, how can they so firmly believe that they're okay, that they have not had an injury? Again, we go back to the faulty tools. If the tools that we're using to measure something are wrong, we're going to get absolutely consistent and absolutely wrong data with which to make our decisions. It is the discrepancy between patients' reports and the reports of others that is often utilized to attempt to quantify the degree of awareness or lack of awareness that an individual displays. When you look at various means of attempting to quantify awareness, they've traditionally fallen into one of four primary processes. And these are some examples, for example, of the self-rate. I'll leave that up for just a second longer. I'm going to talk about each of these, but these are the primary processes that we utilize when we are evaluating whether or not someone is aware. The first one listed here, self-proxy rating discrepancy. It's the difference between how a patient rates themselves and where some significant other or proxy rates them, clinicians often being that as well. The AQ is a 17-item questionnaire that's typically completed by the patient, by a relative, and by a clinician. There are three different versions of this, and so each patient, relative, and clinician fill one out. The items are on a 5-point scale reflecting abilities that are anchored at 1, which is worse, 3 about the same, and 5 better. So anywhere between a 1 and a 5. And these are questions like, are you able to move your arms and legs now as well as you were prior to an injury? Are you able to do fill in the blank like you did before? This instrument is actually available on the COMBI website, the Center for Outcomes Measurement in Brain Injury, and this is within the references as well. So this is one instrument that can be utilized for that discrepancy. Another, the PCRS, is a 5-point scale that anchors on 1, cannot do, to 5, I can do it with ease. So again, it's asking about a variety of different abilities and asking the patient to self-report that, and then asking a proxy to report that as well. A discrepancy score reflects a numerical difference between the patient's rating and others' rating. So if you get a positive discrepancy score on this, it represents that the patient estimates their capacities higher relative to the proxy ratings. In other words, poorer self-awareness. The DEX, on the other hand, is one that really focuses primarily on executive functioning changes. So it has to do with issues of attention, of sequencing, of memory, of things that are more related to frontal executive function exclusively. Structured interviews and semi-structured interviews present a framework of questions that allow for more open-ended responses. And it's the opportunity kind of for expansion of the information obtained. Not a checkbox, not a yes, no, not a Likert type scale, but an open-ended question. These interviews typically focus on that patient's awareness of their own impairments, deficits, and changes that have resulted from an injury, and then, like the previous instruments, require some rating, some degree of agreement between the patient's report and that by others. Typically, a clinician would be the one to fill that out. With the self-awareness of deficits interview, you're interviewing the patient about the knowledge of their own impairments that have occurred since their injury, and then questions focus on the awareness of the functional consequences of those impairments. So you're looking not only at knowledge of injury, not only intellectual, but also emergent and anticipatory. The clinician evaluates the degree of agreement between theirs and the patient's, and again, another 4-point scale here. And the self-regulation skills interview is very closely aligned with the pyramid model of self-awareness. It addresses their ability to recognize difficulties as they're actually occurring, emergent awareness, and also the ability to predict that some difficulties may occur in future situations, anticipatory awareness. These questions typically reflect awareness of more cognitive and emotional function. And then this kind of semi-structured interview, the Self-Awareness in Daily Life, 3rd edition, focuses on more psychosocial issues, family relations, social interactions, intimacy and sexuality, leisure time, work, housing, covers really more kind of psychosocial issues than those prior instruments.
Jeff,
Yes.
do you feel like this needs to be done like within a neuropsych, or
No,
could it be less formal than that?
can
A
definitely
lot
be
of
less
times
formal.
we get requests for both.
Yes.
And I think it's always nice if you don't have to do a full neuropsych battery to determine someone's cognitive ability. So sounds like this is going to be landing in something that you don't necessarily need something like that to assess.
Much more informal. As a matter of fact, I start out most of my neuropsychological evaluations with a brief interview, even though I've got already tons and tons of data. I want to know what that person's report is, and that's one of the questions I'll ask. Why are you here? What happened? Are they aware of the fact that they had an injury? What is different as a result of that injury? That is an open-ended one. Then if they say nothing, then I might get more specific, particularly if they're, seated in a wheelchair. Well, you're in a wheelchair. You probably weren't in a wheelchair before. What is different that now you have to be in a wheelchair, or that you need to be in a wheelchair? And then we'll specifically ask about cognitive functioning, memory,
Mhm.
before I do the assessment, just to get a gauge on kind of what that degree of awareness is. That would be more of a clinician subjective assessment, as this one is. A clinician rating alone isn't really based on any psychometric standard, and so you're not generating measures of reliability and validity, and it doesn't give you data that you can meaningfully use in research findings in and of themselves. That's why those other rating scales exist. But this more kind of informal questioning is also very, very useful, just from the standpoint of being able to look at what are things I need to look at in more detail moving forward within this assessment process. In a performance-based discrepancy measurement, this kind of bridges between assessment and treatment, as we're going to talk about in just a minute. Basically, you are given a task, you want to give the subject a task, and you ask that subject to estimate how well do you think you're going to be able to perform this task. The subject then engages in the task, and once the task is completed, the final outcome is compared with the subject's original estimate. So, how well are you going to be able to do this task? Perform the task, and then go back and look. How well objectively were you able to do the task? If it involves any type of quantitative measure, a measure that produces numbers, that data can allow for a percentage of accuracy measure. For many tasks, however, there's a degree of subjectivity that's involved in the outcome evaluation. So it really depends on the nature of the task. How well you did something as opposed to, I can remember early on in COVID, some of the COVID team were walking around and saying to people, you need to kind of maintain foot distance if you can in public areas. I want you to stand 6 feet from me. And they would have an individual guess what that 6 feet was and stand there. And then they'd pull out a tape measure and they would say, okay, here's how close you were. That is a quantitative measurement of an estimate. And so that's what we're talking about here. Things that you can actually produce a number for. Quantitative data includes things like time of completion. How long did it take you to do it? How far can you walk in 6 minutes? That's a quantitative measure. Physiological measures of performance. How many reps can you do in a given time frame? Those are all things that can produce numbers. How many math problems can you do in a given time set? That is a quantitative data. Qualitative data is more like how difficult was it to perform the task, or what's the quality of the output. Both of these are valuable pieces of clinical information, but they have different uses. Some tasks can produce both kinds of data. If I give you a writing task, for example, I'm going to open up Microsoft Word and I'm going to have you type out a brief paragraph for me about something. I can now measure the number of words produced. It can be a quantitative measure. That's a quantitative measure. How many words did you produce? How many sentences? How many paragraphs? In Word, you can also look up the Flesch reading scale score, the Flesch Kincaid grade level equivalent. Those are both things that you can obtain by running the spelling and grammar check under the Review tab. It shows you just how difficult or how complex is the language involved. On the other hand, the organization of the writing, the efficiency of the information, the flow of the written content, that's more of a qualitative analysis of the end product. And again, either of these can be useful. All right, talk about treatment here. Early treatment processes for self-awareness can be grouped into one of two approaches, either addressing awareness as a deficit that has to be addressed before change can occur, or this latter approach that's the one that makes the most sense in most cases, nesting treatment of that awareness deficit into an integrated program focused on functional capacity. Steve, this is directly what you were speaking to earlier of giving functional tasks that relate to what this individual is motivated by, passionate about, wants to return to. It's really beginning to learn skills and making rehabilitation gains prior to the restoration of awareness. You don't have to be, again, 100% aware to start learning through this rehabilitation process. Hands-on, functional, real-world practice can facilitate improvement in needed day-to-day routines, even in the absence of awareness. And it provides opportunities to facilitate greater in-the-moment awareness for those individuals who are demonstrating emerging awareness. Just from the standpoint of engagement, if you can produce a task for an individual that relates to something that in their life is a part of the routines that they are used to, that they're motivated by, they are going to be more likely to engage in that than if you pull something off the shelf for every patient who comes through the door and have them do the same thing. So individualizing that is going to be better. Most treatment paradigms follow this goal, plan, do, review type, sometimes with the language changed a little bit depending on where you are. This is a performance-based discrepancy paradigm. Remember, that was the fourth of those different ways of assessing awareness that I mentioned earlier. It's also useful for treating this lack of awareness. Again, you give a given task, you discuss what that task is, what's expected, you plan it, you have estimates of performance that are obtained, then you perform the task and you compare outcome with estimate. This paradigm is often used with some minor modifications to accommodate the nature of the task to which it can be applied. But overall, it's a very good practical process that inherently provides cueing to the patient to attend to discrepancies between anticipated and actual performance. This process really facilitates awareness for those with emerging awareness, and it provides repetition for learning to anticipate those situations. Once situation-specific training begins to take hold, it's really recommended that generalization be facilitated, basically through practicing this process throughout the day and across different environments, not just within the confine of our 30-minute or 1-hour session, but throughout the day, being able to informally provide those cues as well. From the standpoint of clinician approaches, common techniques include selecting known areas of deficit that highlight those deficits in initial stages. In other words, if you have somebody with no awareness whatsoever, you want to go for the low-hanging fruit when it comes to things that are easily observable, typically tasks that are more physical in nature, and as a result produce that quantitative data we talked about earlier. You want to highlight difficulties where safety is also a big concern. So you really want to emphasize areas first and foremost that are easiest for the patient to recognize and see. And then as you transition into more of those abstract cognitive emotional type of situations, that would represent, as the patient is improving, you're now challenging to a different degree. Now, the degree to which these situations can be natural environments where the subject is performing a routine or task that's known to them prior to the injury, well, those situations, you're likely to get better buy-in. You're likely to get better engagement from your patient. Another way is using video in trial sessions to allow for more objective or cued observations. In other words, you not only give them a task, you also then go back after videoing their performance and let's talk through that. What do you notice about your own performance? What do you objectively see? Being able to see it in the moment. I've seen cases as well where putting people into real life situations where they don't know necessarily that they're being observed, put them in situations. One that really stands out to me is an individual that was very high functioning, that was taken to the Children's Museum with his kids, and we're just going to have you dropped off here and we'll come back and pick you up in a couple of hours. They were never alone. They had multiple staff members with them scattered around the facility that they didn't know, who were also videotaping those interactions. One person, he had a very young daughter at the time, infant, and a person that he didn't know came up and said, "Wow, your daughter, she is really beautiful. Can I hold her for a second?" And he said, "Sure," passed her over. And then when his back was turned, she kind of stepped around the corner. And it was probably 2 or 3 minutes before he thought to look up and turn around and see where his infant child was. Looking at the videotape was an aha moment that we could not have achieved just in telling him, you have poor in the moment awareness. Your vulnerability is increased because of that lack of awareness. When he watched the videotape, he said, holy, well, I'm not going to tell you exactly what he said, but he was in that moment, I just gave my daughter to a stranger. Okay, I get it. I need to work on this. So sometimes something that dramatic is necessary to get someone's attention that this is an issue. This can be done as well over the phone or via email. We do vulnerability assessments. Every adult knows you don't give your Social Security number to a stranger. But if you called somebody at 8 o'clock at night in their room and say, hey, congratulations, we're so-and-so company. You had entered this contest and you actually won an iPhone, and we're going to be sending it to you. So we just need an address to send it to. And for tax purposes, we'll also need a Social Security number for this. People are much more likely in that kind of phishing situation to give away information that if you ask them across the desk in a formal environment, would you give your Social Security number away? They'd say absolutely not. In that situation, they might be more likely to. So when it's the right time, we actually are doing evaluations like that that are in the real world. Support for family member. Tips include things like providing feedback. And again, not just pointing out what they're doing wrong, but pointing out what they're doing right as well. Remember that positive ratio of feedback. We all need to hear more positives than we hear negatives, or else somebody is just chirping in my ear. Somebody is just telling me everything I'm doing wrong. Cue that individual to be aware in the moment. Even it's okay to do some pre-teaching to say what the risk might be aware of ahead of time, as well as during performance. And this big one, linking rehab to personal goals, this comes from the learning mantras of motivate with meaning. Why does a person want to do it to begin with? And tie it to the task. The thing that you're doing actually ties to what it is that you're motivated by, bringing those learning principles into the home as well. Try to be a guardrail to prevent dangers that you're aware of, but that the patient still needs support for. So minimizing risks, minimizing arguments with that by changing the environment, by modifying the antecedents rather than the consequences. So the big takeaway points that I mentioned at the beginning, and I'm going to hit one more time. Impaired self-awareness is common after brain injury, particularly severe injury. If you have a patient who has had a severe TBI, it is highly likely that that individual will have some degree of compromised awareness. The consequences of having that compromised awareness is it impacts rehab efforts and it impacts outcomes. So we need to be aware of it. We need to pay attention to it. We need to look for it. And it should be clinically addressed when it is there. Now, again, depending on the severity of the issue, that's going to depend on how it's clinically addressed. But the bottom line is we want to improve outcomes for our patients, which is why we cannot ignore this lack of awareness. These references are within the handouts and within the slide set. A copy of this will be available as well. And that covers this presentation. I meant to leave a little bit longer, but we've got a few minutes for questions.
Thank you, Jeff. I am going to launch the poll question, and then if there's any questions, otherwise I have maybe some follow-up comments too that I can bring to the group. Here's the poll question. Reminder, answer this, please. And this helps us get you your CEUs. Use the Q&A if you have some questions. Jeff, while we're kind of letting all this play out, just a quick maybe comment or question around learning from consequences.
Yes.
So, you've talked a lot about assessing and, using some tools to help people, understand and reason through that. I feel like one of the areas that we always get hung up on is this idea of like, well, once they fail, they will learn from that consequence and they will learn then therefore in the future they won't do it. Can you comment on that and maybe the accuracy of that and inaccuracy of that? Because we've talked a lot about the frontal lobe and that's a big piece and component to that.
Well, it's a very valid means of teaching for an individual whose memory is functionally intact, whose cognitive processing is uncompromised. In other words, for somebody who has not had a brain injury and who has complete neurotypical functioning, consequences are a good way to learn. It's how most of us learn. Unfortunately, as human beings, we are somewhat hard-headed and we don't, if we had listened to our grandparents and our parents a little bit more, some of the things that we had to struggle with in life, we probably would not necessarily have had such difficulty with. If we listened to investors who say start early, who of us when we're 23 years old is really focused on our retirement? Not very many, which by the time we get to retirement sometimes can be a real problem. So if an individual does not have the ability to reflect back on and accurately recall their errors or the consequences of their actions, consequences are going to be ineffective. And so when it comes to individuals with severe traumatic brain injury who have often compromised awareness, compromised memory functioning, antecedent control is going to be important. So in controlling the environment, being aware of the risk that exists and attempting to minimize the likelihood of that occurring. It's why second grade teachers, by the second week of school, know that John and Steve shouldn't sit next to each other, because if they do, I'm going to have problems. So antecedent control, environmental control, you make sure that the two of them are not where they can cause problems. Separate them.
Got it. Probably time for one, maybe two more. We have a couple questions and they're around predicting outcomes and then like the level of structure and support clinically needed. So one question around, can you predict how much a patient may recover? And along those lines, do you need to do that in an inpatient setting or can it be done through an outpatient setting?
Well, as always, when it comes to the brain, prediction is really, really difficult. Etiology of injury, location and size of lesioning that might be there, how much of this is associated with lesioning of tissue as opposed to disconnection of diffuse axonal injury. With diffuse axonal injury, depending on the severity of it, there is a greater likelihood of better recovery. With a stroke in a given region of the brain where you have dense loss of tissue, the ability of neuroplasticity to reconnect that area is kind of a moot point if the tissue itself is now compromised beyond viability. Neuroplasticity really depends upon being able to reconnect to some areas of the brain that can actually continue to function and work in that manner. So it depends on a lot of different factors, but basically the longer that this symptom is densely presented, the poorer the outcome is likely to be. That's what most research has shown. If an individual is absent awareness in all aspects months after injury, this is something that is going to likely necessitate outside external cueing and influences in order to keep that individual safe.
Great. I know we're getting up on time. One last question around, and I had the same question. So this is a little bit self-serving, but around like adolescence and age. We have a question around how does this relate to like a teenager or a developing child,
Yeah.
In terms of awareness and probably in terms of executive functioning is going to be my guess.
Yeah.
Land on too. Can you talk about that in terms of age?
Well, it kind of comes down to the age-old question of if you have to be injured at what age. Do you if you say, okay, Steve, you are going to have a severe traumatic brain injury, but you get to pick when you have it. You would probably pick in your late 20s, because at that point you have developed a lot of overlearned knowledge, abilities, and social skills, and you are able to rely upon those overlearned abilities to help support both your recovery as well as your ability to integrate back into the demands of an independent environment. If that injury occurs at a very young age, you would say, well, you have more time to recover, you have more time for neuroplasticity, but depending on the severity of the injury, it can also kind of arrest your development at that stage because you have not had those normal social opportunities, those typical social opportunities that allow you to develop those skills. And it may cause some further delay in your ability to acquire those skills moving forward. So again, injuries that occur in adolescence when the frontal lobes are not yet fully developed, those interconnections are not present. And so you have never really had the ability yet to gain those skills. And that is why sometimes when individuals are injured at the age of 16, particularly if it's a severe injury, neurologically, you are at a disadvantage now to gain those abilities and skills. From a psychosocial standpoint, if you are institutionalized, if you are long-term within some type of institution to provide your care, you're also not going to have available to you those typical social interactions and social development that you would have. And so it's almost like you are arrested at that age from a developmental standpoint.
Mm-hmm. Yeah. And then I guess I would say in the absence of a brain injury, if we're looking at normal adolescent, child development, a lot of the tools that you mentioned can be applied, right? Goal, plan, do, review, and those individuals at that age are going to have some level of ability to learn from consequences, problem solve, reason, and so
absolutely
expect that those treatment strategies per se can be applied to a parenting strategy as well to further develop awareness and
parenting strategies or any other tasks that you do. We inherently do that on our own. Had a little carpentry task that I did this past weekend. And of course, they always say, measure twice, cut once. And the reason they say that is because I cut a piece of wood and I went, oh hell, that's wrong. That's off. So I had to go get another piece of wood and fix it. That was self-assessment between my planned outcome and my observed outcome, and then looping back and correcting an error. And next time I do that, I will use the anticipatory awareness of doing it differently. Yeah, that's great. Probably should quit.
Yeah. Well, we will go ahead and wrap up. There's some questions that we didn't get to. We will address those offline. Thanks again for joining. We will be back after the first of the year. We got a two-part, second and third part of the series on vestibular function. So part 2 will be in January and part 3 will be in February. That'll be with Dr. Snell and Brad Dexter. As a reminder, we will get your email sent, fill out the link to the eval and slides, and the CEU certificate will be quick to follow after that. And with that, happy holidays. Thanks again for joining us in 2023. We will see you all in 2024. Jeff, Laura, Don, thank you.
Thanks, guys.